Hello everyone, welcome to RAAONLINE. I am Dr. Abinaya. I am a consultant pediatrician. In the chapter discussion on infectious diseases, we are going to talk about dengue fever. So there are two presentations on dengue. So this is going to be the national guidelines on the management of dengue fever. So let's get started. So first we'll talk about a little information about the national scenario of dengue fever. So the first ever occurrence of dengue in India happened way back in the year 1956 in Vellore, and few years later, say 7-8 years later, there was a dengue outbreak which happened for the very first time in Kolkata in 1963. So after which dengue had spread all over our nation except for few places in Ladakh, which has not seen even a single case of dengue. And we all have experienced that there is a clear-cut seasonal trend in dengue cases, and this has been happening almost since the last few 5 to 6 years. So as you can see in this image over here, we can see that in the last few years, 2021, 2022, 2019, so clear-cut, there has been so much peak between August to November. So the peak somewhere has started from August, and this is the peak season of dengue fever. So this clear-cut seasonal predilection has been happening over the past few years. When dengue fever started, it usually was more common in the urbanized areas because of the breeding of Aedes aegypti mosquitoes. And the trend now it is changing because of the socio-economic changes, because of the man-made ecological changes has pushed the mosquitoes to invade even the rural areas. So now the transmission of dengue happens in the rural areas also. The dengue virus, we know it is a single-stranded RNA virus from the family, from the genus Flavivirus. So it's a small virus, the size of about 50 nanometers. There are 4 serotypes of dengue viruses, DEN 1, 2, 3 and 4. And a patient can get infected with more than one serotype even at the same particular time. The dengue virus protection has some amount of cross protection with another serotype, but that is present only for a few months, not more than that. And if a patient experiences a dengue fever secondary to DEN 1, then that person has a lifelong immunity only to that particular serotype, not to the other. So the cross immunity to other serotypes is only short-lived. Okay. So this is what you need to understand. So the virus transmission, we know about the extrinsic incubation period, the intrinsic incubation period, etc. etc. So we have seen all this. We have learnt about all this. So just in brief, I am going to discuss. So once the Aedes aegypti mosquito, it gets become infected with the dengue virus, it takes the blood meal from the infected person, and the dengue virus replicates in the mosquito for an incubation period of about 8 to 10 days. So maximum up to 2 weeks. So this intrinsic period is called as the extrinsic incubation period, where the dengue virus stays inside the mosquito. So this is the extrinsic incubation period. So now the mosquito becomes infected, and this virus is then transmitted to a healthy human by the bite of the infected female Aedes aegypti mosquito. In the human, the virus again replicates for a period of maximum 1 week. So this is called as an intrinsic incubation period, right? So this is the extrinsic and the intrinsic incubation period. Not just the transmission happens through the bite of an infected Aedes aegypti mosquito, even vertical transmission, congenital dengue infections have also been reported in the past. So coming to the pathophysiology of dengue. So we know about the capillary endotheliopathy, which is the main pathophysiologic mechanism behind all the manifestations of dengue, isn't it? So we can divide the manifestations of dengue virus either due to a direct cellular injury or by an indirect injury mechanism. Okay. So after a mosquito bite, the dengue virus gets inoculated into a healthy human. Okay. So once it gets inoculated into the human body, it undergoes viremia, that is the virus keeps getting replicated. So this virus can either cause a direct cellular injury or it can cause indirect injury or both. Okay, so mostly it causes both direct and indirect injury. Where the direct injury happens? Predominantly in the endothelial cells. So that is the capillary endotheliopathy is the pathology. By capillary endotheliopathy, it causes the macrophage activation, it causes platelet dysfunction and platelet destruction. Okay, even if the platelets are normal in count, it has a dysfunctional environment. It doesn't function well also. Even though the counts are normal, the platelets don't function well. Okay, so platelets get destroyed. Also, the platelets dysfunction happens. Indirect injury mechanism is by both getting affected, both the cellular immunity and the humoral immunity, both are getting affected. One is called as the production of antibodies, which is antibody dependent enhancement. This is called as an ADE. So antibody dependent enhancement, and T cell activation causes increased chemical mediators which takes the human body by a cytokine storm. Ultimately what happens? Vasculopathy, that is endotheliopathy happens, coagulopathy happens, organopathy happens, the cells are involved, cells are damaged, so cytopathy happens. So this is the main pathophysiology of dengue. There is a, if you can go through the guidelines, actually all these are explained in detail. I have just put in a simpler form here. Okay. So severe dengue will manifest with the entire, that is a multi-organ damage will be present. There can be a massive bleeding with shock. So coming to the clinical manifestations of dengue fever, either it can be asymptomatic or symptomatic. So dengue fever predominantly it is a mild febrile illness. Mostly 90 to 95% it is a mild febrile illness. Only 2 to 3% maximum enters into the critical phase and then they can go for a severe dengue infection. So who enters into a severe dengue infection is mostly dependent on some of the factors. First thing is the age, extremes of age. An infant more than 65-year-old. So the extremes of age are prone for severe dengue. 1. Nutritional status, immune status, immunocompromised patients, those children who are underweight and who have comorbidities. Next is a secondary dengue infection. So already infected with the same serotype or co-infection with two different serotypes. So all these will have a higher or will have a severe dengue manifestation. Dengue fever has a short incubation period. So it has a short incubation period right from 3 days to 5 days. Okay. And we know that there are 3 clinical phases. First is the febrile phase, next is the critical phase and third is the convalescent phase. So right now we have the monsoons and this is the season where we are beginning to see a lot of dengue fevers. So any fever during this particular peak or seasonal peak I told you, right, starting from August to December, if you get a patient or if you get a child with fever, a short duration fever, 2 to 7 days duration with 2 or at least 2 or more than 2 of any of these manifestations, please do think of dengue. Okay. So fever 2 days with 2 or more than 2 of anything, headache, body pain, retroorbital pain, arthralgia, rash, hemorrhagic manifestations, some warning sign. I will talk about warning signs and warning symptoms later on. And in case you take a blood investigation, it shows leukopenia or thrombocytopenia, definitely do think of dengue. Okay. So before you can go for an ELISA based test and before you have done any investigation or you have done only rapid antigen test, you can label the child as a probable dengue fever. Okay. So the definition of probable dengue fever is as per the definition. So as per the clinical description, 2 days fever with some 3 symptoms of the above. Headache was there, retroorbital pain was there and any other myalgia or rash was there, arthralgia. So something has there, something of any of these symptoms was there. So I am going to label that child as probable dengue fever before I am going to do the ELISA, right? Or if someone has done a rapid antigen test, rapid diagnostic test and NS1 has come positive. So if it is a rapid antigen diagnostic test and it is positive, please label it as a probable dengue fever. Only when it is an ELISA based test, you are going to give the diagnosis as an as a confirmed dengue fever, right? So confirmed dengue fever is mostly we do an ELISA based test. In the first 5 days of illness, you are going to do the NS1 based ELISA test. Clear? A dengue fever, you have a suspicion that this child could be a dengue illness. So, you are going to do the ELISA test. If the child is within the first 5 days of illness, please do an NS1 based ELISA. If the child is in day 6 or day 7 illness, fever is continuing, please do an IgM ELISA. Okay. So, otherwise, the viral PCR nowadays, that is also quite common. So, if you have accessibility to dengue PCR, you can do that. The virus culture or virus isolation or the fourfold increase in the or the seroconversion or the 2 weeks fourfold increase of the IgG levels, all these are of theoretical importance. We are not going to do that. Okay. So, either NS1 ELISA, IgM ELISA or a viral PCR. If it is positive, you are going to tell the child as a confirmed dengue fever. Clear? Okay. Now, we will go to the clinical phases of dengue. So, clinical phases of dengue, as we know, the first phase is the febrile phase, second phase is the critical phase and third phase is the recovery phase. So, the febrile phase usually lasts 2 to 3 days, okay, 2 to 3 days, sometimes it can even last up to 5 days. So, this is the febrile phase. Critical phase usually lasts 24 to 48 hours. In case there is a multi-organ damage, there is extensive coagulopathy, such instances, the critical phase can extend a little longer. Otherwise, critical phase is usually between 24 to 48 hours. Next comes the recovery phase. Recovery phase is usually complete by day 10 of illness. Okay, this much you understood. Next, in febrile phase, what is the temperature? It can reach as high as 40 degrees Celsius. This is very high temperatures, continuous high grade fevers will continue till the critical phase sets in. And even in the critical phase, it can come up to a lower body temperature and again there can be a peak, as you can see here. Okay, it has come down below the baseline and then again picked up. So, this is also possible in a critical phase. In recovery phase, there is completely no fever, right? Next comes the clinical issues with each of these clinical phases. First, in the febrile phase, the clinical issues dehydration because of high fever, poor oral intake, there can be dehydration. Second, in the critical phase, there is capillary endotheliopathy. There will be so much of losses, capillary leak is present in this phase. So, there can be shock or because of the coagulopathy, because of the platelet dysfunction, there can be bleeding also. In the recovery phase, what happens? All the extracellular fluid will enter into the intravascular space and that will cause reabsorption, fluid overload, pulmonary edema if you don't have the proper input-output balance. If it is too much of a positive fluid balance, then you are going to be in trouble. Next, coming to the laboratory changes, hematocrit is normal or it is appropriate for that particular hemoglobin level. And in the critical phase, because of the capillary leak, the hematocrit is going to increase. So, the hematocrit is going to increase, there can be hemoconcentration and again during the recovery phase, it can go in for hemodilution, right. So, what happens to the platelets? So, the platelets are initially normal, slowly from the febrile phase itself, the platelets are going to drop. Okay, as you can see here, the platelets have started dropping even in the febrile phase, keeps on dropping in the critical phase and then it starts increasing. Okay, and what about the investigations? So, I told you in the first 5 days of illness, please do the NS1 antigen based ELISA. Because of the viremia, the NS1 antigen will be released. Do the NS1 antigen levels in the first 5 days. Later on, you can do the IgM ELISA. Okay. So, this clinical phases of dengue, you should be very well versed with. So, the febrile phase again, whatever we have mentioned already. So, one thing I want you to know is the rash. So, the rash, as you can see here in the febrile phase, is a maculopapular rash, generalized occurrence and it blanches with pressure. As you can clearly see, the person's hand print is there. So, clearly blanching with pressure. So, this is a rash in febrile phase. Whereas, there is one more different kind of a rash in the convalescent phase, I will show you. Even in the febrile phase, apart from fever, this rash, arthralgia, myalgia, retroorbital pain, some abdominal pain, vomiting can be there. bleeding manifestations will be present in the febrile phase also. Okay, so it is not that bleeding manifestations should be seen only in the critical phase, not like that. Physical examination, usually dengue children we can see from the outside, will be able to identify. Their face looks very puffy, they have this rash, very irritable children, and they have hepatomegaly or tender liver will also be present. Tourniquet test should be done for all children with a suspected dengue, and because even though platelet counts can be normal, petechiae will not be visible, but when you do a tourniquet test, you will be able to identify the bleeding manifestation. If tourniquet test is positive, then you have to see the patient very carefully. In the critical phase, only around 5 to 10% of the children who are in the febrile phase will go for the critical phase. Okay, so they have to be admitted, their input, output, their vitals have to be very closely monitored in such children. So, critical phase usually is seen in children who have a secondary dengue infection, who have comorbidities, whose weight is very low, and usually critical phase lasts for 24 to 48 hours. So, all these features of critical phase I have already explained to you. So, some of the warning symptoms and signs. So, I want you to write down these warning symptoms and signs and stick it in your files, okay, or have it in the wards, because when you admit dengue children, or you can even write it down in the case sheets or have some letter pads where you can give it to the parents also. So, child comes to you in the febrile phase, give them and tell them if the child is vomiting, if the child is telling right-sided abdominal pain, very lethargic child or very restless child, any bleeding. So, any of this warning symptom or warning sign is present, please ask them to come back. This is very important. So, I usually give it to the parents and also put it in the word. If any of this warning symptom or sign is present, inform immediately. Okay. So, you palpate, you have a liver more than 2 cm below the right costal margin, if you can, and when you have admitted the child and then you see a clinical or a serial increase in hematocrit, again that is a critical phase. Rapid increase in hematocrit, more than 20% rise from the baseline is a warning sign. So, very importantly, we have to see the hematocrits. So, again, not all children present to you with shock, but in case they present to you with shock, initially it will be a compensated shock. Okay, compensated shock, we very well know that the heart rate will be high, the pulse pressure will be very narrow, the pulse volume will be low, CFT will be prolonged. This much every one of us know. It is similar, same whatever you know about the shock, it should appear in this tabular column also. So, monitoring of the BP, always see for the diastolic BP. If the pulse pressure is getting narrowed, if it is becoming 20 or less than 20, means the child is in a compensated shock. We need to optimize fluids for these children, right? In the convalescent phase, what happens? Convalescent phase usually starts after the critical phase, or sometimes children do not go through the critical phase at all. So, directly they go to the convalescent phase. So, usually they are completely afebrile, their appetite comes back to normal. They have a convalescent rash. So, the convalescent rash is usually pinkish rash with small islands of hypopigmentation. So, it is called isles of white. So, this erythematous rash with this small areas of sparring. So, that rash is usually pruritic, okay. And during the convalescent phase, we can also see a relative bradycardia in such children, okay. What we need to be very careful of in convalescent phases, do not please stop the IV fluids, encourage oral fluids. If you are giving IV fluids during convalescent phase, definitely the person will have morbidity because of the pulmonary edema or because of the overhydration, okay. So, be very careful. So, how are you going to approach the diagnosis? Already I told you any short duration illness. So, a fever 2 to 7 days, and I told you some of the clinical pointers for dengue, isn't it? So, 2 or more than 2 of any of those features if present, please do a dengue ELISA based test based on the day of illness and based on the positivity. So, if the ELISA comes positive, you have to then see what type of dengue this or what category of dengue this person fits in. So, there was one slide where I have written all the warning signs, isn't it? So, if no warning sign is present, this child will go in for dengue without warning sign, that is a mild dengue only. If there was warning sign, the child will have a diagnosis for dengue with warning signs. If severe dengue means the child has shock, the child has severe bleeding manifestations, multi-organ dysfunction is present. So, severe dengue, profound shock. So, dengue with warning signs, dengue without warning signs and severe dengue. So, these will be your syndromic diagnosis. Again, the warning signs I have mentioned, some comorbidities. Comorbidities and high risk will be, one I already told you, extremes of age. So, infancy and old age. Any other comorbidities like diabetes, hypertension, immunocompromised states, hemoglobinopathies. You can see this picture over here. So, it is telling about all the comorbidities. So, all these will come under moderate dengue. Severe dengue will be shock, bleeding and multi-organ involvement. Okay. So, the organ dysfunction in dengue will be innumerable. So, most of the organs will be involved. So, when coming to the nervous system, there can be encephalopathy, there can be seizures, there can be aseptic meningitis, GBS is also possible, transverse myelitis is possible, GI symptoms. Hepatitis is what we usually see, fulminant hepatic failure very rarely, pancreatitis, even acute parotitis. Kidney, there can be acute renal failure, hemolytic uremic syndrome. Heart, there can be myocarditis, pericarditis, conduction abnormalities. Lungs, there can be ARDS and pulmonary hemorrhage. In musculoskeletal system, there can be myositis with increased CK levels. There can be rhabdomyolysis. So, involvement of the lymphoreticular system can complicate and present as HLH. There can be ITP. In eye, there can be optic neuritis, macular hemorrhage. And so, all these are various organ dysfunctions in dengue. So, lab diagnosis we just discussed about the ELISA based tests. So, this is what we are going to do. So, ELISA based tests are very simple test which is highly specific and highly sensitive. So, this NS1 is an antigen which is a non-structural protein antigen, and this is present in abundance in the serum of patients during the early stages. And NS1 is very specific for dengue virus, so it is able to differentiate between the other flaviviruses also. IgM ELISA is again, it's a very simple test which is done beyond the day 5 of illness, and mostly the IgM levels in the patient's blood is seen up to 60 days. So, in case the particular area is not very endemic to dengue, we can just randomly do the IgM levels, which will be for surveillance purpose, it will be useful. Okay. IgG ELISA is only able to differentiate between primary and secondary infections. It is not a diagnostic test. It is going to indicate only past infections. Again, isolation of the virus takes time, around 7 to 10 days. The virus isolation can be done from specimens like serum, organs like liver, spleen, lymph nodes, thymus, of course, they are all autopsy tissues, and mosquitoes also. The recent technique is the PCR, so the molecular diagnosis based PCR. So, these methods are also now gradually replacing the ELISA test. So, this is a very popular test, that is the rapid diagnostic tests. So, the rapid diagnostic tests are very common and they are very commercially available also. We get very quick results, but the accuracy of these rapid diagnostic tests is of questionable importance. So, and also they give a high rate of false positivity. So, currently the national guidelines do not recommend these tests. It is better and always best to go for ELISA based techniques, right. So, now coming to the management of dengue illness. So, we can classify as mild, moderate and severe dengue. Mild dengue only needs home care, and we should give clear-cut instructions. You write in their case sheet or about the warning symptoms and when the parents should bring the child for follow-up. So, the mild dengue, mainly the bed rest, oral fluids, body temperature, if it is high, it should be reduced by antipyretics. This is what we are going to tell, okay. So, paracetamol, bed rest, adequate oral fluids. So, in oral fluids, ensure the importance of giving ORS, tender coconut, etc. Okay. And warning signs have to be educated to the parents. So, moderate dengue or severe dengue you are going to admit, and either in the wards or in the ICU depending on the criticality of the patients, and identification is very, very important in these children. So, these children, moderate to severe dengue, they need monitoring, very, very critical and vigilant monitoring. So, at least every 2 hourly, and if there is shock, every hourly they have to be monitored. And again, serial hematocrit levels, every day at least you need to have 2 to 3 values. Urine output should be at least 0.5 ml, more than 0.5 ml per kg per hour. Lab investigations, of course, these are mainly to, you will do hematocrit and hemoglobin, platelets, etc. But for involvement of the other organs, you need certain blood investigations. Okay, you will do a serum electrolytes, RFT, sugar, LFT, and coagulation profile, chest radiograph to rule out any pleural effusions. Cardiac enzyme we will do only if you suspect myocarditis. Serum amylase, of course, to rule out pancreatitis, ultrasound abdomen to see for any gallbladder, hydrops, ascites, etc. So, these are all, like most of it we do for all the patients. Serum amylase enzymes alone, based on the case to case basis we can do. Okay. So, now coming to the algorithmic approach of management of dengue. So, first is dengue with warning signs. Okay. So, first you have assessed the child, and warning sign, we know that there is bleeding, petechiae, there is a high hematocrit. So, when there is hemoconcentration, you are going to start the fluid at 7 ml per kg at least. Okay. You start the fluid at 7 ml per kg in the first 1 hour, because there is a high hematocrit. You know a baseline. From the baseline, more than 20% it has increased. Okay, so you start at 7 ml per kg for the first 1 hour. Then at the end of the 1 hour, look for the improvement. For the improvement, what you are going to do? Look at the vitals. Look at the heart rate. Look at the blood pressure, CFT, the pulses, and do a hematocrit. And urine output also you should check. If the heart rate is decreasing, if the pulse is of good volume, if the urine has started coming, and if the hematocrit has started falling, it means the child is showing improvement. If there is improvement, what next? You are going to decrease the fluid rate. So, you have started at 7 ml per kg per hour, you can come down to 5 ml per kg per hour. In case you start at 10 ml per kg per hour, thinking, okay, it is, the pulse pressure is also very narrow, I need to push fluid, so you can give a 10 ml per kg for 1 hour. It's not a bolus, 10 ml per kg over 1 hour. Okay. You give over an hour, and then there is improvement, you are going to taper it. If you start at 10, you come to 7. If you have started at 7, you come to 5 ml per kg per hour for another 2 hours. Again assess. If there is improvement in parameters, decrease it to 3 ml to 5 ml. Then at the end of 2 hours, assess and then use decrease. So, you have to decrease the fluid, IV fluids at a step-by-step manner. When there is clinical improvement, you are going to reduce the fluid accordingly and stop the IV fluids in 24 to 48 hours. There is no strict rules that you should definitely give fluids for 2 days. No, nothing like that. When the child is in critical phase, even for the 24 hours alone, it is enough. Okay. As much as in dengue, please encourage the child to take orally. In case you have started the crystalloids, 7 ml or 10 ml per kg you have given over an hour, but there is no improvement. Okay, either the hematocrit, you are looking at the hematocrit, it has increased more than 45%. Okay. So, now what? If it is increasing more than 45%, now I should repeat one more 10 ml per kg of crystalloid, or if I have an access to a colloid solution, I can give colloid at 10 ml per kg. So, one colloid 10 ml per kg can be given. Now, you assess after an improvement. If there is improvement, yes, reduce it from 10 ml to 7 ml, 7 ml to 5 ml. So, keep reducing it. If there is no improvement, even after a second 10 ml per kg, even after a colloid, then you should consider that the capillaries are damaged. This is a case of refractory hypotension. You can start on inotropes. Okay. If there is hematocrit which has rapidly fallen, you saw that before 2 hours, the hematocrit was 44 maybe. Now it is only 35%. So, such a rapid fall, it means that there is a major bleeding which has occurred. Okay. If you can identify the source of bleeding, you have to act accordingly, and for the source of bleeding, what we have to do, that also we have to do, and along with that, we have to do blood transfusion. Blood transfusion, ideally we do packed RBC. So, 5 ml per kg of packed RBC we give first, and then further blood transfusions will be decided as per the patient's condition. In case the child has a severe dengue, but there is a compensated shock, okay, the BP alone is maintained, only it is very narrow pulse pressure. So now also you are going to do the same thing, you start the crystalloid at 10 ml per kg. Now there is no 7 ml per kg. So either you start at 10 ml per kg or directly you can go for 20 ml per kg because there is a compensated shock. So 20 ml per kg for 1 hour you can give, and then again you assess. If there is improvement, keep reducing the crystalloid rate accordingly. If there is no improvement, either it is a bleeding or it is a persistent capillary leakage is there. So you increase it, you give a second bolus. If no improvement, consider hypotension and start on inotropes. If there is decompensated shock, you rapidly give the bolus 10 ml to 20 ml per kg. If there is no improvement, give a second bolus. If no improvement, again give a third bolus, try colloid. Finally, if there is no improvement at all, it can be a cardiogenic shock or a septic shock, start on inotropes. And there is metabolic acidosis, if there is hemorrhage, you have to treat accordingly. Colloid you have to try. So these patients, very rarely this scenario happens. These patients should be managed at an ICU level. Okay. So now you have started IV fluid therapy. I told you when should you discontinue. So more than 48 hours, it is not at all necessary. If the patient's parameters, hemodynamic parameters are normal, the child doesn't have any fever, he has a good oral intake, then please stop the IV fluid. Okay. And next is indication of platelet transfusion. So before some 15 to 20 years ago, when dengue protocol or the guidelines were not established, people were giving platelet transfusions very commonly. But now that is not the scenario. We have come to an understanding that the bleeding is not just because of decreased platelet number. It can be because of platelet dysfunction. It is because of the capillary damage. It is because of coagulopathy. So now there is no point in giving platelet transfusion after and after. Okay. So only if there is bleeding, along with PRBC, you can give platelets. If the platelets level has reduced to less than 10,000, you can give prophylactic platelet transfusion even without a bleed. Or if there is an emergency surgery which has planned or an emergency procedure, you are going to put a central line, something like that, any emergency procedure, you can give a platelet transfusion, not otherwise. So whenever there is a severe hemorrhage, try to identify the source of bleeding. If there is epistaxis, pack. If there is an UGA bleeding, do an endoscopy and identify the source and do the necessary. And mostly we give PRBCs. If PRBC is not available, fresh whole blood can also be given, right? So in the convalescent phase, what we usually feel is that there is a bradycardia. There can be some hypokalemia because of diuresis. So, and rash is also seen. So during the convalescent phase, give a good nutritious diet, ask them to take good potassium rich sources in the diet. So when the child is recovering, there will be good return of appetite with no vomiting, no abdominal pain, good urine output. The hematocrit will be very stable, the temperature will be normal, the child will be hemodynamically stable, no bleeding, and there can be a convalescent phase which is very pruritic on the extremities. Okay. So this is about the national guidelines on dengue management. Very simple guidelines, very practical to follow. Okay. So stick to these guidelines in your day-to-day practice. It will go in a long way for you and teach you a lot of things, and each dengue patient is different. Okay. So try to do everything as per protocol, always vitals monitoring, input output monitoring, please don't forget in dengue. Okay. So I hope this session was helpful for all of you. Thank you so much for the patient listening.